start. ಈಗ 5
In view of
seconds.
persistent respiratory distress and
ಅಂದ್ರೆ ಈ ಮೋಡಲ್ಲಿ
second dose of surfactant was given on the same day and the baby was electively intubated. The mechanical ventilation was continued from day 1 to day 6 of life. On day 3 of life, Pda echo was done, which showed a large PD of 3.2 mm with bidirectional shunt with severe PAH with good biventricular function. So IV paracetamol course was started. Extubation trial was given on day 6 of life, uh, but the baby did not tolerate extubation, and in the extubation failure, baby was reintubated, and ventilation was continued from day 6 to day 15 of life, and the second dose of second course of IV paracetamol was given. Other aspects like sepsis was treated with IV pig test for 14 days, and the baby was on total parental nutrition and minimal enteral nutrition from day 1 to day 15 of life. Serial 2DFO was done. Uh, on day 3, the size of the PDA was 3.2 mm, large PDA with bidirectional shunt with the 3 mm costume second of PST with a good biventricular function. And day 6 of life, it was 3.2 mm with bidirectional shunt. Day 7, it was 2.8 mm with large PDA with bidirectional shunt. And on day 13 of life, it was a 4 mm PDA with the left to right shunt. With the dilated LA-LB with grade 1 MR with LA by AO ratio of 2.14. In view of hemodynamically significant PDA, which was not uh, able to be managed medically, surgical ligation was planned, and baby was referred to Indira Gandhi Hospital on day 15 of life. The concerns or main issues at the time of admission at IGSH were there was a large hemodynamically significant PDA, 4 mm, with failed medical management to close PDA and prolonged mechanical ventilation and one extubation failure. And there were deranged renal functions and altered brownish aspirate at the time of admission. So, course at IGSH, baby was received on day 15 with ET Institute. Respiratory distress was mechanical ventilation was continued. Baby was not in shock, no inotropes were initiated. Since baby had altered aspirate and deranged renal functions, ibuprofen was required. And requested for surgical ligation of PDA. And the baby was taken up for surgery on day 2 of admission. The post-operative course was the left thoracotomy with PDA ligation was done on 22nd of March, and baby was started on noradrenaline infusion intraoperatively, and post-operatively we had continued mechanical ventilation, and noradrenaline infusion was continued at 0.1 ml per kg per minute, which was tapered and stopped over the next 36 hours. As the BP was normal throughout the course, no further inotropic support was started. Continued on mechanical ventilation from post-operative day 1 to day 5, and chest X-ray was suggestive of pneumonia, and IV antibiotics were given for a total of 7 days. The post-operative and baby was weaned off from ventilation on post-operative day 5 and continued on NIMS support from post-operative day 5 to day 8, and weaned off to CPAP from day 9 to day 10, and then to HFNC. Nutrition feeds were reinitiated on post-operative day 1 along with TPN, and we were able to reach full feeds by post-operative day 6. I'd like to show X-ray and this was the X-ray post-operative. There were signs of bilateral haziness and lower lobe infiltrates were noted. This was the 2DA done post-operatively. You could see the PDA ligation. There was no PDA visualized. I'd like to tell a few points on PDA and just medical management. The ductus arteriosus, it is there in the fetus, which is connects the main pulmonary artery to the descending aorta, and it is necessary for the fetal circulation. The persistence of this ductus arteriosus, that is the patent ductus arteriosus, in the neonatal period, it is the most common cardiac condition affecting the neonates. And it is functional closure of PDA occurs between 24 to 48 hours of life, and anatomical closure occurs over the next 3 weeks. This is usually in the term neonates. The incidence of PDA is more as the gestational age of the child decreases, and the spontaneous closure rate also reduces as the gestational age decreases. As we can see in a full-term child, a full-term neonate, the ductus arteriosus is closed on day 4 of life in 100% of the neonates. Whereas as the gestational age decreases, the percentage of ductus arteriosus, the percentage of closure on day 4 is very less. And the percent, this is, we are talking about the spontaneous closure. As the gestational age decreases, we can see more than 30 weeks of gestation, 98% of the ductus arteriosus is closed by the time of discharge. Whereas babies born less than 28 weeks of gestation, to extreme preterms like between 24 to 25 weeks, only 54% of them are closed spontaneously. The pathophysiology of PDA. Why it is of significant importance is the PDA, patent ductus arteriosus, in a neonate causes left to right shunt. PDA with the left to right shunt, it causes mainly pulmonary overcirculation and systemic underperfusion. That is because of the left to right shunt, and majority of the left ventricular output going into the uh, pulmonary circulation. So pulmonary overcirculation causes, and all of these blood is coming back to the left atrium and the left ventricle. This causes left atrial dilation as well as increased preload on the left ventricle. The preterm's myocardium is not able to tolerate the increased preload, so it compensates it with increase in the heart rate rather than increase in the stroke volume of the preterm myocardium. Along with that, as there is increase in left ventricular preload, it causes increase in the left ventricular diastolic pressure. This causes the circulation to the coronaries in the diastole is reduced. So it further causes compromised coronary perfusion, which further decreases the stroke volume of the baby, further worsening the cardiac output. At the same time, it also causes systemic underperfusion. Right shunt, the systemic perfusion is reduced. Uh, there happens a phenomenon called sweet phenomenon, where the blood is pumped from the descending aorta as well as the thoracic aorta into the pulmonary aorta, causing decreased circulation in the systemic decreased systemic circulation. This results in various clinical features and manifestations. When we have to suspect a PDA, usually when we see clinically in a preterm child, if the baby has respiratory distress RDS, initially we would have treated with an appropriate respiratory support and we would have given a surfactant, and the baby's condition would have improved because of the treatment. Then suddenly, like on day 3 to day 5 of life, the respiratory distress worsens, and we usually see persistent tachycardia, increased FiO2 requirement. Then we have to suspect for PDA. This happens because once the RDS is treated, the pulmonary pressure further falls and the systemic pressure increases, which worsens the left to right shunt, which causes these manifestations. So clinical signs include persistent tachycardia, bounding pulses, that is easily palpable dorsalis pedis pulse, and wide pulse pressure because of the diastolic runoff, and hyperactive precordium, where we can see precordial pulsations in more than 2 rib spaces, and murmur. Many infants with a large PDA may have an audible murmur, and because of decreased systemic perfusion, it results in oliguria, renal failure, and because of compromised renal flow. And similarly, because of compromised mesenteric blood flow, it results in feed intolerance. In an already ventilated neonate, there will be increase in ventilatory settings, increase in ventilatory requirement, oxygen requirement, and hypercarbia, mixed metabolic acidosis can be there on BBG, and uh, prolonged ventilatory requirement, inability to wean off the baby from ventilator, as we had seen in this case, and presence of recurrent tetanus. Uh, this is about when we have to suspect hemodynamically significant PDA. Uh, these are the risks. The lower risk for hemodynamic significant PDA when there is no tachypnea, no tachycardia, and minimal respiratory support, and no abdominal signs or symptoms, and no signs of organ dysfunction, and echocardiography is fairly normal. In higher risk group, there will be tachypnea, tachycardia, and increase in respiratory support in the form of invasive ventilation, and abdominal signs in the form of feed intolerance, abdominal distension, signs of pre-NEC signs, and other signs of organ dysfunction like renal failure. And on echocardiography, there will be signs of left to right shunt, which results in the changes in the cardiac, like dilation of the left atrium, left ventricle, increased ventricular increased cardiac output, and those changes will further discuss in the next. These echo findings of hemodynamically significant PDA includes again classified into two things: pulmonary overcirculation and signs of systemic hypoperfusion. Signs of pulmonary overcirculation includes LA by AO ratio, which is increased because of the increased pulmonary overcirculation, which returns to the left atrium. I'd like to welcome. So the signs of pulmonary overcirculation includes increase in the LA by AO ratio. That is that as the pulmonary, because of pulmonary overcirculation, the return of blood into the left atrium causes left atrial dilation, which causes increase in the left atrium as compared to the aortic diameter. And isolated relaxation time is decreased because of tachycardia, the IVRT is reduced, and the left ventricular output, as we discussed, it will increase in severe hemodynamically significant PDA. To diagnose systemic hypoperfusion, uh, the flow in the flow across the abdominal aorta, flow across celiac artery, flow across middle cerebral artery state. In mild cases, the flow is fairly normal. There will be forward flow. In moderate cases, there may be absent flow, whereas in severe cases, there will be reversal of flow in these arteries. It is suggestive of systemic hypoperfusion. So coming to medical management of PDA, most of the PDAs in preterm neonates are known to grow spontaneously with time. As I shown the chart, more than 30 weeks of gestation, nearly 90% of the PDA will grow spontaneously by the time of discharge, whereas in less than 30 weeks of gestation, the spontaneous closure rates are very less. The main strategy for medical management includes fluid restriction and appropriate ventilatory strategies depending upon the distress of the baby. And the pharmacological closure of PDA involves the use of NSAIDs. So fluid restriction involves it is recommended for both prevention as well as management of PDA. Uh, Not more than 120 to 130 ml per kg per day of fluid should be given beyond day 3 of life. And at the same time, as we have restricted the fluid, we should watch for urine output as well as serum sodium levels and renal functions. Ventilatory strategies: we should keep a higher beat as it will help with reducing the left to right shunt and decreasing the TA time. It will help in oxygenation.
How much weight do you use? Like so maximum how much do you use?
5.5 to 6 is the, like, as the baby's gestation is lower, we keep a higher.
Oh, oh.
In PDA, we will keep a higher peak, usually 6.
6.
Uh, FAO2, try to keep it as minimum as possible. FAO2 is not bad.
Sorry.
The target maximum-
The target is saturation between 90 to 95. So depend on that, if I would keep it right.
This way we have done volume guarantee implementation with data volume of 4.5 ml per kg. With that peak of 6, we have implemented. And FAO2, the maximum FAO2 requirement in this study was 50%.
Maybe the score shall be clear.
The next day it was less than 30%. The pharmacological closure of PDA. It is used if PDA is contributing to the hemodynamic compromise and if non-closure may be associated with morbidities. For example, in extreme preterm babies, signs and symptoms of PDA along with echo-proven hemodynamically significant PDA. And any preterm unit with severe symptoms related to PDA like congestive cardiac failure, pulmonary hemorrhage, pulmonary edema, inability to wean off from mechanical ventilator support. In these cases, we consider the pharmacological closure. The 3 drugs which are available for pharmacological closure include indomethacin, ibuprofen, and paracetamol. Indomethacin is given at a dose of 0.2 mg per kg, followed by additional doses of 0.1 mg per kg given at 12 hours interval, total of 3 doses. It is associated with reduced risk of IVH, but it is associated with other complications like increased risk of NEC, uh, renal failure, and intestinal perforation. So, because of the benefits, increased complications compared to benefits, indomethacin use is in decline. Ibuprofen, again there are 2 dose regimens. One is standard dose, another is high dose. Standard dose is 10 mg per kg, followed by 2 additional doses of 5 mg per kg, given at 24 hours interval, total 3 doses. Higher dose is first dose of 20 mg per kg, followed by 2 additional doses of 10 mg per kg, given at 24 hours interval. The the closure rates in both indomethacin as well as ibuprofen is the same, comes around 70%. And it is as effective as indomethacin with a lower risk of NEC as well as transient renal insufficiency. The other complications associated with ibuprofen includes IVH, increased risk of IVH, pulmonary hemorrhage, sepsis, ROP, intestinal hemorrhage, convictors. It is usually contraindicated if there is renal function impairment, signs of NEC and thrombocytopenia and active bleeding. In the case which we discussed, the baby had altered aspirate as well as renal functions were altered, so ibuprofen was preferred for treatment. Paracetamol is given at a dose of 15 mg per kg every 6th hour for 3 days. In some scenarios, if it doesn't dose for 3 days, a second course can be given, or the duration of the dose can be extended from 3 to 7 days. And it is associated with lesser adverse effects as compared to other NSAIDs. Complications include hepatotoxicity, and it is contraindicated if there is NEC and impairment of renal function. AAP recommends total. There is no clear-cut regimen for treatment of PDA. Broadly, the treatment strategies can be divided into 4. One is targeted prophylaxis. In targeted prophylaxis, all the neonates are treated between 6 to 24. All the neonates who are at risk of PDA are treated between 6 to 24 hours of life with indomethacin. With this targeted prophylaxis, even some neonates who it is like undue treatment of PDA. In early targeted PDA, PDA is treated when the baby is less than 6 days after birth. Asymptomatic PDAs are treated in early targeted PDA before the baby develops any symptoms. In the third category is treatment of symptomatic infants with HSPDA. This is what we usually follow. When the baby develops hemodynamically significant PDA, the treatment is initiated. The last treatment strategy is the rescue treatment, where select patients after failed COX inhibitors are given with the background. Coming to surgical ligation of PDA, we have to consider surgical ligation of PDA. Uh, when there is failed medical management and when there is contraindications for medical management, like already the baby has VEC, JA perforation, renal impairment. If the PDA is persisting beyond 2 weeks of life, again the medical management won't work in beyond 2 weeks of life. So these are the indications for surgical ligation. And complications associated with surgical ligation of PDA includes post-ligation cardiac syndrome, pneumothorax, chylothorax, vocal cord palsy. And studies have shown that early surgical ligation is associated with a higher risk of developing BPD, ROP, and neurodevelopmental impairment. But again, surgical ligation will reduce the mortality in these. Coming to the major complication after surgery, that is post-ligation cardiac syndrome. Uh, Risk factors for developing this post-ligation cardiac syndrome is more in if the surgery is done before 4 weeks of age, and if the gestational age of the baby is less than 26 weeks, if the birth weight is less than 1 kg, and there is already a need for inotrope prior to the ligation. Uh, the main pathophysiology of post-ligation cardiac syndrome involves as soon as we ligate the ductus arteriosus, the left to right shunt is stopped. Therefore, when there was left to right shunt, majority of the left to right shunt, that is pulmonary hyperperfusion, was coming back to the left atrium and left ventricle. Suddenly, this venous return is hampered or stopped. Therefore, there will be decreased preload. At the same time, there will be, as the PDA is ligated, there will be increase in afterload. Both the decreased preload as well as increase in afterload causes left ventricular dysfunction. This usually manifests around 6 to 12 hours after the procedure, and the decreased preload is more significant at the time of surgery when the PDA is ligated. This is the image discussing about the pathophysiology. That is, as the PDA ligation, it reduces the pulmonary venous return, which will in turn result in reduced preload to the left ventricle. And ligation leads to a sudden left ventricular exposure to increased systemic vascular resistance, which causes increase in afterload. So both reduced preload as well as increased afterload causes systolic dysfunction as well as diastolic dysfunction of the left ventricle, which causes decreased cardiac output. So the algorithmic approach for to avoid this ligation syndrome is pre-ligation. We have to evaluate preoperative echo should be done to determine the severity of the PDA, and other routine preoperative blood work should be done. And it is also associated with decreased release of uh, steroids in the body. So ACTH stimulation has to be done to assess for stress response. 1 hour post-operatively, we should do post-operative echo to determine the left ventricular output. If the left ventricular output is less than 200 ml per kg per minute, then we should consider for inotropic support like milrinone. And adequate ventilation strategy should be addressed. And at 6 to 12 hours of post-operatively, we should monitor both systolic as well as diastolic blood pressure. If systolic blood pressure is less than third centile and diastolic blood pressure is normal, we should consider dobutamine and volume support by giving the fluid bolus. And if diastolic blood pressure is less and systolic blood pressure is normal, then you should consider dopamine. And if both systolic as well as diastolic blood pressure is less, should consider volume support and use of hydrocortisone. In this way, we continuous intra-arterial BP monitoring was done, and the BP remained stable throughout 48 hours post-operatively. So we are not initiated in further inotropics, but we have continued giving hydrocortisone for 2 days.
What's the role of hydrocortisone?
Stress response will be reduced in these days. adrenal is not affected. So have you got some
Adrenal.
Why it lead to BPD and other issues post ligation? What is the mechanism?
That actually whatever they do,
It's very early, no?
when they used to ligate more of the
Is it something like the moment you close up the PDA, will it have some change in the pulmonary point BPD is happening?
that study whatever they do was done in pre-steroid
We don't know really it's surgical
actually
related.
PDA reduces PDA ligation reduces. The result could have happened very early. In the first time you give a follow-up to the delivery, that time itself the would have been so surgical basis and very old.
Even also the incidence of NEC, all those things ideally you should reduce. So unless they have a NB dysfunction, they should reduce it.
But it can happen if perioperatively and postoperatively if you don't take care of the fluid and shock.
Correct.
Still it can happen.
Yeah, that part of the shock is not technically.
Yeah.
And these
Yeah.
PDA ligation, these are
Simple question.
side
ACTH stimulation test is required for all the babies. When you are giving hydrocortisone, anyhow, you are wasting the time and also maybe the response may not be all that great for a small baby. Standards are not all that great. The cortisol value is normal, electrolytes are normal. For the age related.
empirically we have modern.
Pharmacological version of the
Paracetamol is the first of this thing was rate of remission.
yeah, isotonic IV was not available before, right?
You oral, now also.
Yeah, but you are right.
You are the last few months.
So you used to use oral
He was mentioning about the paracetamol oral. Can we try paracetamol IV also?
IV
Not in oral.
Both IV or oral.
If oral is available, that is the first.
Did you find that paracetamol was slower or anything less efficient? For that.
So why oral is preferred?
Those are right, both are the same.
Why oral is preferred?
Studies have shown oral is.
But oral,
Yeah,
how
oral
you
is
fresh and how much you go inside or? That's superior than intravenous.
That is available evidence. Not compared to intravenous, but whatever studies they have done is oral prescription.
Because Brufen was not available intravenous, so paracetamol may not come. Because of course absorption rate can be less also, no, that babies usually will be sick in such cases. That absorption will be less. But there is no option for Brufen.
Did this baby have any ROP or anything?
No, the previous screening is not.
No.
But ROP and all, it usually is because of the hypoxia or whatever the effect of PDA can lead on. PDA is not a direct effect
PDA
on.
and prolonged ventilation.
Yeah, prolonged ventilation, those things. So. Otherwise, PDA has nothing
Not
to
due
do with
to
it.
PDA is also.
PDA in that.
No. Hypoxia, ventilation,
Not
prolonged
really oxygen
ventilation,
potential.
even BPD also. But BPD, we need a little bit of changes in the missing also. Respiratory epithelium to develop BPD. All the columnar epithelium, all those things should be replaced by Cuba.
Post circulation, prolonged pulmonary post circulation.
Yeah, that's true, but it takes some time. That can happen even after pediatrician also when the baby is put on ventilator and if it requires ventilator for some prolonged.
It's not really in between for 15 days.
15 days.
By the time diagnosis is made and the patient comes for the ligation, it would have already gone through for some at least 10 15 days because the treatment options of breathing respiratory distress.
RL's only PDA. So we'll be doing echo once we diagnose PDA in NACA. to assess the severity. But this mild and moderate PDA, and may not have some of the symptoms also. Most of the PDA are picked up later on.
Some PDS can directly present as a complication in form of ADCs or APs. When they develop, then we could have picked up PDA.
That will be severe this PDA.
Not necessarily, even mild to moderate also can be.
Because the anatomy it is like this only, it is triangular and the base is at this and the apex is at pulmonary artery. So the flow may be somewhat restrictive also because of the conical aspect is at pulmonary. So but, but but in neonatal period, PDA presenting with the failure and coming
They can present.
severe.
That usually with the normal term babies, the PDA is not stable. Plus this one. Premature, they are already in the hospital. Normal delivery, after 1 or 2 days, they discharge, they come back with respiratory distress. Then you find that the PDA is large and you then have to.
Thank you.
Very nice. Thank you, Dr. Darshan and Dr. Niranjan, sir, for the enlightenment on the medical management of PDA in preterm neonates. Now, we shall look into the anesthetic consideration of preterm neonate for PDA closure. The session will be moderated by Dr. Madhvi ma'am, and the presenter would be a fellow from anesthesia department, Dr. Soumya.
Good afternoon. I'm Dr. Soumya from Department of Anesthesia, and I'll be presenting a case of an early preterm neonate posted for patent ductus arterial ligation. Dr. Darshan has already covered the birth history of this child, so I'll directly skip to the pre-anesthesia examination. So in the preoperative examination, we have an ex-preterm neonate who was already intubated with a 2.5 uncuffed endotracheal tube. She had pink extremities, capillary refill time was within 3 seconds, and a PICC line was already present in the left lower limb. The vitals pre-op, heart rate was 148, respiratory rate was 72 cycles per minute. On a mechanical ventilation with FiO2 25%, her preductal saturation was 95% and postductal saturation was 90%, and the blood pressure was 52/24. On systemic examination, respiratory system showed bilateral equal air entry, normal vesicular breath sounds, no added sounds, but subcostal retractions were present. The cardiovascular system S1, S2 were heard, and a systolic murmur was also appreciated. Per abdomen, soft, non-tender. Blood investigations were all within normal limits. Hemoglobin was 14.6. And the 2D echo showed a large patent ductus arteriosus with a bidirectional shunt, severe pulmonary artery hypertension with good biventricular function. So in preoperative preparation, we had kept the neonatal monitors and equipments ready. Warming blankets, hotline, warm fluids, and ambient OT temperature was maintained to have a normothermia in the perioperative area. Infusion pumps were kept ready, blood products were confirmed, and the post-operative ICU bed with ventilator was also confirmed. Any transport requirements, including AMBU, transport ventilator, and oxygen cylinder, was also present. Consent forms were checked, and antibiotic prophylaxis with Pda injection was given. Intraoperatively, we had connected a preductal and postductal pulse oximeters. Initially started with a non-invasive blood pressure (ECG) and the ventilator monitors, including EPCO2 and agent monitors. Although all cases may not need invasive blood pressure, after induction we did secure an outline as well. So for induction, since our child was already intubated, we have connected the pre-existing 2.5 ET tube with a pediatric closed circuit and started inhalation of isoflurane 1% with a air oxygen mixture of 40% FiO2. So fentanyl bolus of 4 microgram was given and atracurium bolus of 2 milligram was given. Here I'd like to mention that this was high dose opioid fentanyl induction. Usually we would give around 2 microgram per kg of fentanyl, but in these cases, any cardiac neonate cases, we can give 4 to 100 microgram per kg doses. And opioids usually are more cardiostable than our conventional induction agents, so here we chose fentanyl. Also, we continued the fentanyl and atracurium as infusion, and we mixed these both in a single infusion pump such that if we keep the setting at 1 ml per hour, we'll get a fentanyl infusion of 2.5 microgram per hour and atracurium infusion of 1 milligram per hour. The reason for doing this is we wanted to decrease the overall IV fluids given to the patient throughout the intraoperative period. So mechanical ventilation was continued in PCV mode, similar to the NICU settings, which was PA inspirator pressure of 50, rate 25 breaths per minute, FiO2 40, and a PEEP of 5. And IV plasma light was also set on an infusion pump with 3.5 ml per hour. As I said, the PICC line was already present, but we secured another 22 gauge cannula in the right upper limb, and the left femoral arc line was also placed. So vitals post-induction, we had an invasive blood pressure of 55/15. You can note the diastolic hypotension. Heart rate was 149 beats per minute, respiratory rate as per the ventilator settings, and with an FiO2 of 40%, preductal saturation of 96 and postductal saturation of 92%. The child was positioned in right lateral position, the thoracoscopy ports were placed, and insufflation pressures of 5 mm mercury were set. At this point, we saw that the mechanical ventilation with the ventilator was having difficulty adequately ventilating the neonate. So we overtook the ventilation with the Jackson Rees circuit, and we ventilated the patient with low tidal volume and high rate. So the decision for this type of ventilation was to provide a clearer field for the surgeon and prevent overexpansion of the lungs so that the surgeon had a better field. A few intraoperative events which I want to highlight. During thoracoscopic manipulation around the aorta, it caused vagus stimulation leading to bradycardia. And as we know in neonates, cardiac output is more heart rate dependent. This drop in the heart rate caused a severe drop in the blood pressure to 26/10 mm mercury. This was immediately communicated to the surgeons and we proceeded with a slow and staggered approach. Another event that happened was there was blood loss during the thoracoscopic manipulation. So a NORAD infusion was started at 0.1 microgram per kg per minute, and whatever blood loss happened, we started to slowly replace it with fresh frozen plasma. Also during the cardiac manipulation, we had one single episode of ventricular tachycardia, which was treated with a single bolus of injection lignocaine 1 mg. And in case further arrhythmias occurred, we also considered a amiodarone and kept it standby. At this point, the surgeons decided to abandon the thoracoscopy and it was converted to a thoracotomy. During the thoracotomy, we did not experience any further complications. Just one point is during clamping of the ductus, there was initial improvement of the diastolic blood pressure from 10 to 25 mm mercury, followed by a drop in both systolic and diastolic pressure. This hypotension was treated by titrating the existing NORAD infusion to maintain an MAP of more than 40, and 30 ml of fresh frozen plasma was given over 30 minutes. Here, I'd also like to mention that we gave a bolus dose of hydrocortisone, as Darshan had already mentioned in PDA patients. Because of chronic hypoperfusion to the peripheral organs, they usually have adrenal insufficiency. So this can be a cause of refractory hypotension. Hence, the decision to give hydrocortisone. So this protocol has already been discussed by Dr. Darshan. The same thing we had followed. After successful ligation of the PDA, hemostasis was achieved. The thoracic cavity was checked for any air leaks, intercostal drain was placed, and the thorax was closed uneventfully. Normothermia was maintained throughout the procedure. At the end, we had a total blood loss of around 10 ml. Total IV fluids of plasma-like 28.5 ml. This included all the infusions and all the boluses and the diluted drugs that we were given. And fresh frozen plasma 30 ml was replaced. The child was shifted to the NICU with ambu ventilation on an infusion of NORAD of 0.05 microgram per kg per minute and a fentanyl infusion of 4 microgram per kg per hour for post-operative analgesia and tube tolerance. The transport was uneventful and the stable neonate was handed over to the NICU doctors. So just a brief discussion of the anesthesia management. In the pre-anesthetic checkup, we'd like to see the ventilator settings and the FiO2 requirements of the neonate, which the neonatologists were following, and the same thing we'd like to continue into the perioperative period. Also, many a times these preterm kids will be on multiple inotropes or high dependency on the ventilator. We may not always be able to shift them to the IC. So whether shift them to the OT. So whether the procedure will be done in the OT or if it has to be done in the ICU should be noted. The echo should be reviewed and discussion with the surgeon whether single lung ventilation is required or not. We should check for adequate vascular access and endocarditis prophylaxis must be given. On induction, like I said, high dose fentanyl is what we usually prefer, with or without an additive benzodiazepine. If at all there is no IV cannula already present in the child, we can also go for mask induction with slow increments of sevoflurane, watching out for any signs of cardiac depression, hypotension, or bradycardia. And again, I'd like to stress that we use the minimum FiO2 required because if unnecessarily giving extra oxygen can cause oxygen radical stress and retinopathy of prematurity.
So, about pulmonary vasodilatation, they have talks.
Yes.
So that's going to increase the pulmonary pressure, and because of that, the duct flow will increase. Yes, and that is the way.
So, intra maintenance, again, whether we need one lung ventilation or two lung ventilation is adequate. Low dose volatile anesthetics can be used, and we can continue with the opioids and neuromuscular blocking agents. More than boluses, it's always better to use infusions to decrease the overall IV fluid that's used. Again, lowest FiO2 possible. Now, in post-operative care, we have to highlight the pain management. So, thoracotomy pain leads to ineffective chest expansion, leading to atelectasis and hypoxemia. So, we can continue with the high-dose opioids here, as they reduce the post-operative inotrope and vasopressor use, and it mitigates respiratory compromise. Alternatively, paracetamol can also be considered. And if we're thinking of blocks, intercostal nerve blocks, erector spinae blocks, or paracortical blocks can also be thought of. So some complications which were already highlighted, inadvertent ligation of the aorta or pulmonary artery. So sometimes the PDA will be as big as these major vessels. So we have to make sure, or the surgeon will make sure that the correct artery was ligated. Any nasal vessel injury can cause hemorrhage. Dissection near the vagus can cause bradycardia, as happened in our case. Any thoracic duct damage can lead to pylothorax. Recurrent laryngeal nerve injury will cause vocal cord palsy, which will usually be seen in the post-operative period once the child is extubated by change in voice or a change in cry or stridor. And hypotension and arrhythmias, as we have seen. So take-home points are we have to maintain the pulmonary vascular resistance to prevent any right to left shunt. The heart rate, contractility and preload, with more emphasis on the heart rate, has to be preserved to maintain a cardiac output. Preductal and postductal oximetry has to be kept. And to determine the ligation of the correct vessel during clamping and maintain normothermia, something we should not forget, especially in the preterm neonates. In conclusion, the collaborative efforts of the anesthetist, surgeon, and neonatologist, along with support by experienced nursing and OT technologist team, are indispensable for success of such major cardiac surgeries, ensuring the best possible outcome for our smallest patients. Thank you.
Sir, please add.
It's very well managed. There's nothing much to add.
You can tell your experience.
Yeah, this is very well managed and nothing much to add. But yes, you have put one femoral vein artery in the, yeah. The most important is most of the times better to have one femoral artery cannulated before the ligation, because I have seen 3 times in my experience the descending aorta was ligated, and this especially my problem is we are on bypass and suddenly we feel that the pressure is low because we have just now gone on bypass. But within another 2-3 minutes, we have to realize that the descending aorta has been ligated and alert the surgeon that he has to release that and do the PDA.
But always you do under bypass.
No, madam, this is most of our cardiac cases in which PDA ligation is done after we go on bypass, because the PDA will be quite tense when if we do it off bypass. But as you said, just PDA ligation, yes, we have had quite a good amount of problems. Then another thing about monitoring is what I usually do is if the why femoral artery again is sometimes coarctation is missed when the echo is done, and this gets highlighted the moment the PDA is ligated. So it is better to have a femoral artery rather than a radial artery, though the femoral artery trace becomes blunted and you might not have a good trace while the aorta is manipulated and when they are dissecting for the PDA. But still, femoral artery is better because it avoids one complication of descending aortic ligation, and the next one is it highlights if there is any associated coarctation which has to be tackled in the immediate period. Then about monitoring of the upper part, I usually what I do is this pencil Doppler which we use in the ICU to detect the pulsation in the peripheries, that is kept at the right carotid close to the patient, so you can continue to hear the sound, so that it's very difficult to keep the hand on pulse when the pressure is on the when they are manipulating the aorta, and you may not get a good temporal pulse. But this pencil Doppler gives you a good sound and it alerts you that the cardiac output is not like if madam might remember, age old we used to put an esophageal stethoscope to monitor the heart sound, and depending on the sound we used to tell that oh, blood pressure is come down, give some volume, which was maybe very early way of doing those things. So here I usually use, if I don't get a radial, especially when coarctation is also to be done, we keep a pencil Doppler at the carotid level, and that gives us at least some amount of cardiac output sound which is heard throughout the procedure. And next about the ventilation. The surgeon, if it is open, they usually take 3 gauze and one down, one towards the heart and one up, or the lung is packed. So then it is the JR circuit which is going to do the job, and with an FiO2 of the 25 to 30%, we have to hand ventilate these patients, because as the CO2 builds up, the pulmonary artery pressure goes up, and that in effect raises the tensile strength of the PDA, and it is liable to break when the ligation is done. So we have to keep the pulmonary pressure on the lower side and continue to hand ventilate till the ligation is done.
Use anything to reduce the pressure?
To reduce the pressure, before we used to dilute the sodium nitroprusside and GTN, but of late we only use around 3% isoflurane.
That's all.
Yeah.
No
that-
ATG, nothing.
Nothing. So isoflurane, we just start the moment they start dissecting the aorta. If the pressure is on the higher side, we start adding isoflurane and continue to hand ventilate, so that the pressure also comes down to around 50 to 55 by the time they get the PDA. And one more thing is the surgeon usually hooks up the aorta above and below to have a good control, and also the PA, so that if there is some breakage, you don't lose all the blood out. So many of them, what they do is they partially clamp the ascending aorta and ligate the PDA so that the pressure is even lower and it will be convenient for the surgeon to ligate the PDA. Then,
Sir, about the arrhythmia.
yeah, arrhythmias and when you manipulate the aorta, yes, there is all the sympathetic and parasympathetic fibers are on the great vessels where they go and supply to the required organ. So what we do is when the moment they start manipulating the aorta, ask them to spray 1/2 cc of xylocard over the surface so that all the surface twigs will get anesthetized, so then the amount of response will be less. Though there are fibers which are present in the media also, when they pull too much, you do get response. But at least the surface fibers are anesthetized. And we do the same after coarctation repair also. And we spray the surrounding area around the ligation, because the PDA which is ligated will be left there only when it is ligated and the coarctation is repaired. Then you spray that area with sensor clean itself and close the pleura. So the up to 4 to 6 hours in the post-operative period, you find a very good control of the blood pressure. There will be no unnecessary hypertension, which calls for most of the times to start milrinone. Again, that will be increasing the contractility, and both the sides the blood pressure will be trying to go. So
Which inotrope you use intraoperatively? Which do you prefer?
inotrope, usually dovitamin is chemical injected. We don't, most of the times dovitamin, especially if this PDA ligation or coarctation, we don't use any inotropes at all. And it is only with the some amount of extra fentanyl is given to control the blood pressure. Otherwise, very rarely. If it is hypertension in ICU, then they start milrinone to reduce the diastolic and help the myocardial contraction. Volume,
So
volume,
prophylactically you don't start anything.
no, prophylactically, no.
So intraop, if there's any.
If there is any hypertension, just give 1 or 2 cc of calcium, the heart becomes, the blood pressure comes back to normal. Very good, because they are dependent on calcium very much for the contractility, and we just give 50 to 100 milligram per kg, or just 1 cc or 2 cc diluted, you give it, immediately the pressure turns to normalization. And even after isoflurane, when we have used for almost around 5 to 10 minutes till the ligation is done, then again the surgeon is the pressure is not coming up. So you just silently give 2 cc of calcium, the pressure will come back to 70 or 80, and the hemostasis can be complete without any problem.
Do you keep the blood order before?
Yeah. That's the same. I instruct them that to order for blood the moment surgeon scrubs inside. So by the time it comes, it takes 20 minutes.
Yeah.
So by the time he's either on the PDA or ligated. So the moment it comes, if it is not required, send it back immediately. So this is what happens with all these people. Better, madam. 2 times I have had a bad experience where nothing connected to the PDA. The thoracic one vein opened up, and the patient, it was a same premature, which was they said that the patient can be weaned only after you ligate the PDA. So then we went to MSH to do the ligation, multiple specialty hospital. There we took in the theater, but still at the end of during the procedure, one vein opened up and patient blood to a blood pressure of same 25 systolic. Then I just gave albumin because we had ordered and the blood had not come into the theater. Managed with albumin and then replaced it with blood before shifting to the ICU. This it has happened. And still worse is, we get the PAH has to be managed even after ligation, though we feel that now the PDA is ligated, the pulmonary hypertension doesn't settle so quickly because it is already a battered lung for ventilation of 10 to 15 days, and most of the times there is prematurity, the hypertension of prematurity has not settled, and these patients will continue to have. So most worst thing which we can expect is that RV dysfunction in the immediate post-operative period. And I have had one when we had a like 8-year-old PDA ligated and everything done and just shifting to the cot patient arrested. That was secondary to severe PAH and the RV dysfunction had set in. So that is where we usually keep dobutamine so that it takes care of both the, in case it is required. And if it is only heart rate and PAH is the trouble, we even many a times have started isoprenalin 0.25 milligrams diluted in 50 ml and started around 0.03 to 0.05 miles. That keeps the heart rate also a little higher and may help in getting the pulmonary blood pressure lower. That's the experience.
So isoflurane, using it to reduce pulmonary
The isoflurane they reduce systemic pressure. Pulmonary pressure won't that much. It is correspondingly, actually, if it reduces pulmonary pressure, there will be more flow into the lungs, as I said. So it is better not try to do that. Systemic pressure to be brought down for ligation. So the best thing is some of the surgeons, they themselves, they would have passed their rubber, this thing, they just nut that and get the pressures further down and get the PDA.
We had used isoflurane.
Isoflurane 2 to 3% and depending on the timing of the surgery, 3% immediately if you want, around 2%. You will get nice bradycardia and hypertension both. So that will give a good time for them
But
to
they have to be
get.
very quick, is it?
No.
Because that
We'll
hypertension.
give the time to them so we.
They were very quick actually.
Yeah.
10-15 minutes, I think they.
Anything else? Yes, sir. Please.
Yeah. Just wanted to know that I was seeing that PDA rupturing in your entire career.
No, sir.
During time,
That,
that is opened up.
that way, because of that fear, I think it has not ruptured. If you don't have the fear that it is going to rupture, it will rupture. So I'm
Point
not.
well taken. Second is for a
And many a times, if the PDA is too big, you dissect the ascending aorta and descending aorta, and dissect the pulmonary artery partly, put side biting to the pulmonary artery side there, and they snug the aorta proximally. So then it becomes totally supple. You pass, you prior itself pass thread and keep it. So it becomes either double ligation or triple ligation of the PDA. We don't put clips. It is silk ligation, which is
So in all routine PDAs, if you think there is a bigger PDA, then better to have a VA and the ascending aorta, descending aorta control.
dissected and
Three points.
controlled. Because by chance if it
Nuggets.
gives,
Yeah,
you have
nuggets.
nothing else. Within no minute, the whole blood will be in your field and you can't do anything. So best is to have the control over these two. Or at least you dissect adequately that you can put a clamp. Though you may not go around the aorta and take this thing thread over that, you will just get space to put a clamp. So that if you clamp also the flow and the loss of blood will come down to the minimum.
So you have to clamp both the PA and aorta. Both.
No,
And
not
aorta.
ascending aorta and descending aorta. So then it become very easy for it. But PA also you have to have it in hand so that control. The LPA has to be under control. Otherwise, the blood from the LPA will start flooding the field.
Now people are doing thoracoscopically, sir.
Yes, sir. Thoracoscopically, Dr. Devi Shetty and Muralidhar have done it in 2000 itself in Manipal Hospital. They have got paper also presented.
So with
But that's
during
not
that
in
period of
neonate.
time also.
Not with but
Neonate.
neonate, they have started doing quite a few of them now, but those were usual PDA ligations which were done in it.
So in those patients also, they used to loop the aorta and PA.
No,
and
that one,
thoracoscopic also.
no, I'm not sure whether what they were doing at that time because I've not gone through the details.
Because many of them they are not doing it. So this looping of the aorta.
No, in the theater when the surgeon, our surgeons usually, because most of the times, our problem is the cardiologist finishes of all the small and medium sized PDAs by device closure. The one which comes to the theater will be at least 1 centimeter in size. The 1 centimeter in size, and they would have even tried putting a device in that would have embolized and into the descending aorta or into the LPA distal. So we have to take the patient, ligate, take out the device, and then send it. So that is the
point-
smaller ones as what was highlighted. So that may not require that much of
dissection and getting into that.
Most
In
of
case
our-
we feel that the PDA is big, it is better to have the proximal control at least, so that you don't lose much of blood.
Yeah, that's the point, sir. Now, when we are trying to do it laparoscopically, that
You
is
cannot-
technically more demanding and
More.
you have snuggers, 2 or 3
No.
snuggers around there.
It's difficult.
So that's the fear of rupture is always better.
The fear of rupture will keep you preventing
Grounded.
all these steps to prevent rupture.
Thank you, sir. Thank you so much.
I would like to thank Dr. Keshavamurthy sir for his valuable inputs and Dr. Madhvi ma'am for moderating the session. Now, we shall dive into the surgical aspects of PDA ligation. This session shall be presented by Dr. Vinupriya ma'am, Assistant Professor in the Department of Pediatric Surgery, and the session is moderated by Dr. Narendra Babu sir.
Good morning, one and all. We are now going to discuss the surgical aspects of PDA ligation. A brief history on the PDA ligation. The first PDA ligation was done by Dr. Robert Cross in 1938 in Boston Children's Hospital. I don't know how many of you are aware of the story behind this history. Actually, Dr. Robert Cross was a senior resident in pediatric surgery, and his boss was, or his chief was Dr. William Ladd. And for a long time, there was a lot of discussions in the European countries about how to proceed with this condition of PDA ligation, and there were a lot of dissections happening on autopsy specimens and animal models. But Robert Cross had not got a go-to from Ladd, so he couldn't proceed with the surgery. So he was waiting for Dr. Ladd to go on summer vacation to do the surgery. So the in-charge chief actually gave him a go-to, and he finally did the first PDA ligation on a 7-year-old girl, and which was successful. But later he was reprimanded, and then later he got back into practice. And by the time he retired, he had 1,400 PDA ligations in his logbook done by himself and his residents. So it was a pediatric surgeon who did the ligation of PDA first. Then the transcatheter occlusion came by Boltzmann in 1967, and the BATS approach was done first by Francois Laborde in 1991. So the indications has already been discussed, is the failure of pharmacological management in symptomatic child, or there's contraindication to pharmacological treatment, inability to wean from mechanical ventilation, left ventricular damage, persistent cardiac failure, persistent or recurrent renal impairment, and persistent hypotension requiring inotrope support, and candidates not amenable for transcatheter device closure. The timing of surgery is actually controversial. We don't have a clear-cut guidelines on the timing of surgery. Early ligation, few literature says it benefits the preterm babies compared to late ligation when with respect to better respiratory, neurological, and nutritional outcome. But as such, there are no clear guidelines. Briefing about the PDA histology, the media of the patent ductus arteriosus is actually deficient in elastic fibers. That makes it actually more friable to rupture when a lot of extensive dissection is done around the PDA during surgery. It has poorly organized smooth muscles arranged in spiral fashion. These smooth muscles are actually very responsive to the pharmacological treatment and when done early. As the time goes on, the response actually goes on decreasing. And there is intimal thickening due to mucoid. Coming to the surgical approaches, we have open approach and the minimally invasive, that's the VATS approach. In open, the most commonly employed approach is the posterolateral thoracotomy, usually done on left side, and right it is preferred when there is a right-sided aortic arch. So posterolateral thoracotomy, and the thorax is entered either in the third or fourth intercostal space. Median sternotomy is preferred in older children when there is a large PDA and cardiopulmonary bypass is contemplated. Coming to the techniques of ligation, the techniques of ligation could be a simple suture ligation, which is the preferred approach for a preterm child. Silk suture tied across the PDA. Or it can be a metal or hemolog clip application. We can combine both suture and clip application. Or we can do a double suture ligation. One freehand silk suture type, and second is periadventitial suture is first-rate kind of suture is taken. This avoids the slippage of ligation. Division and oversewing, where control is taken on the PA side of PDA and the iotic side of PDA, and then it's divided and it's oversewn in 2 layers. And it's important that after oversewing also the iotic end. The iotic end we take horizontal sutures to reinforce so that it doesn't open up. And for an older child or a calcified PDA, what they do is we go on cardiopulmonary bypass, we open on the pulmonary artery, we identify the orifice of the patent ductus arteriosus, we use a PTFE patch and we do a PTFE patch repair. This is done after taking the child on cardiopulmonary bypass, putting on hypothermia, and then we have to establish low volume status. Minimally invasive approach is the VATS approach. We use a camera port and 2 working ports, one for the retraction of the lung and second for the clip application. Critical intraoperative steps would be, the most critical is the anatomical detailing. This is crucial to avoid accidental ligation of aorta, left pulmonary artery, or even the bronchus. And always respect the vagus and the recurrent laryngeal nerve. Avoid extensive dissection and skeletonizing the patent ductus arteriosus, and especially in pretermers. And it is advocated to actually perform a second time out before PDA ligation, so that we are all of them in the operating team are actually clear about the anatomy, so that we avoid these catastrophic events. A brief note on the transcatheter occlusion. We can either use coils or duct occluder devices. The most common one uses the Amplazer. This is the nitinol device. It also has polyester patch, which will actually promote thrombosis. It is available in various sizes and configurations. So the access would be either a prograde route, that is the venous route, or a retrograde, that's the aortic route. There's an angiographic classification of PDA. This is based on the configuration of PDA. Type A is conical, type B is window, type 3 is tubular, type D is a complex one, and elongated is the type E. This configuration is important to know which kind of the device occluder are you going to use. So this is an intraoperative picture of PDA, and this is prior to device employment and post device employment. Residual PDA or recanalization. This can happen due to suboptimal occlusion. It is the least with ligation and division technique. The incidence varies from 3% to 23%. They are mostly trivial and hemodynamically insignificant, so might not warrant any kind of treatment. But long-term complication of infective endocarditis has been mentioned. So whenever we have to go in again for the management of residual or recanalized PDA, the options would be we can go for either a transcatheter approach or surgical fusion. The complications of surgery are bleeding, pneumothorax, vocal cord palsy or recurrent laryngeal nerve palsy, chylothorax, diaphragmatic palsy for phrenic nerve injury, post-ligation cardiac syndrome or post-ligation cardiorespiratory syndrome, which has been elaborated already. Post-ligation cardiac syndrome is because it's the hypotension that results because the left ventricle is not able to take the load of sudden increase in the afterload and decrease in the preload. Post-ligation cardiorespiratory syndrome is where there is increased systemic vascular resistance and increased pulmonary blood flow, which causes pulmonary edema and plethora. Infections. Bronchopulmonary dysplasia, retinopathy of prematurity, and neurodevelopmental impairment initially was actually multiple retrospective analysis showed that the incidence of these 3 complications were higher whenever we did surgical ligation of PDA. This is because of complex interplay of ischemia reperfusion injury that happens during around in the perioperative period because of the hypotension that happens. But over a period of time, the concept has been changing. Now it has been contemplated that it is because of the prematurity of the baby itself that is causing the complications, not the surgical management. The case details is already mentioned. It was a 23-week preterm child with respiratory distress. This was the intraoperative. First, we started with a VATS approach because the working space was lower with the VATS approach. We converted it to thoracotomy. And thoracotomy, the delineation of structures. The suture is on the mediastinal pleura. So we have had a suture for retraction on the mediastinal pleura. You see, and the reticular vascular tape is around the PDA. And we can see the vagus nerve, which is being shown through the forceps, and the recurrent laryngeula, which is looping around the patent ductus arteriosus. We have the pulmonary side and the aortic side. And this is, we have deployed a hemologin. So the take-home messages would be, surgical ligation of PDA is feasible with negligible perioperative mortality and well within the pediatric surgical domain. Intraoperative anatomical detailing is crucial to avoid a catastrophe. And second, time out is actually preferable prior to ligation so that anatomically we are clear of the structures we are ligating, and teamwork will lead to better outcomes. Thank you.
Any discussion? Any discussion?
We were actually planning to do a video for a long time. So because the topographically we have ear and cardiac surgery is somewhere
Yes.
there. So shifting the baby there, shifting back the baby, it was a more demanding. And we also, I think they also experienced a lot of issues. Then we thought we have to attempt it. And we used to call the cardiac surgeons here only. But sometimes we used to not, their calendar, our calendar is not able to match. So somehow we have to find a balance. This is the time we find balance now. So technically, sir, basically when we did this adenogram, the bradycardia is because we are putting pressure on the cardiac cell. We are trying to retract the lung.
Yes.
We are able to feel the cardiac pumping on the forceps itself.
That's why I said 3 small gauze pieces usually what the one in the center, one above and one below. That isolates the lung from your side. And since the structure is the posterior mediastinum, so the heart and the lung is pushed forward. And hand ventilation with low tide volume will not flood your field. So it helps in maintaining
So
the
when we did thoracoscopy, one of the thoracoscope forceps was
Was-
putting pressure on the heart. That's the time we had multiple episodes of desaturation.
And
hypertension,
as you said, the moment you find bradycardia and hypertension, you have to alert the surgeon that you are pressing too much.
So once we opened that, I don't think they had any problem.
Yeah. No. After opening, in opening cases, it won't happen in thoracoscopy because again inflation and there be some. And it is just till we do few cases after that everybody becomes more competent.
Now after your inputs, we feel more comfortable.
I think it's only anatomical detailing is more important. Technically, it is easy to do. But yes, we should be grounded that there is a possibility of rupture always.
Yeah.
We cannot
No,
be
ruptures have
overconfident.
happened on bypass than by doing
Okay.
they just keep ligating and we have had enough of where we again cool and then repair that.
At least if the bypass is there,
Yeah, bypass is there, so we are very safe that there is nothing much extra to do except cooling.
Clip versus ligation, which one would the
Yes, sir.
The clip versus ligation, which one would
Most even after ligation, our cardiologist would have written residual PDA present, so they would like to ligate only rather than put a.
So the metal clips actually can dilate, sir.
Yeah.
But this is a US clip. Once it get locked,
Okay.
it will not get unlocked.
Yeah, they were using metal clip
These
sometimes,
are not,
so that it's not.
But then you like it enough.
Because basically this is being, most people who start doing thoracoscopy,
Yes.
it's easy to put a clip once you isolate.
No, so thoracoscopically it is easy to put a clip rather than put a
Then,
stitch because you have to go around. It's a very difficult task, and even with slightest extra movements, the PDA will. So, that's-
I would once again like to extend my gratitude to respected Dr. Keshav sir for enlightening us today and all the other departments for their active participation and valuable inputs so that we can do better in our further management. And may we look forward for further such sessions where we can together discuss about any case. We can now discuss for the refreshments which have been arranged. Thank you. We would like to thank our sponsors by Vicon Company for providing us with the refreshments. Thank you.
Hello, colleagues. Hello.